Uh, Greetings to all the people, particularly the panel members. I'm not mentioning each of your names since I won't say it properly. But the way we started the session has been very, very special. It's been fantastic to talk about mental health, self-care, and recognition that all of us need mental health rather than only people with mental disorders. What I plan to do in the next 20 minutes or so is to focus upon what is the exciting thing that's happening in the modern therapeutic strategies for mental health. I thought with that limited time, I will choose two topics for that. One is cognitive behavior therapy. The second one is lifestyle for mental health and physical health, since that was the theme of the American Psychiatric Association last year. So it's a very important topic. But before I do that, I want to place the current situation, the journey of mental health, taking us back to 200 years back when Dorothea Lynde Dix, who started number of mental hospitals, said this just to remind us how far we have come. She said, hospitals are the only places where insane persons can get better and they can be taken care of humanely and properly controlled. From there, we have come a long way in the last 200 years. After things, besides cognitive behavior therapy, which is of 50 years origin, the other major development that occurred was by Freud at the beginning of the 19th century. I'm mentioning it to connect it to CBT in a minute. I will do that. Freud's work was very important because he moved the dialogue from the bad, mad to sad. I'm playing with words in the sense that all of us are vulnerable. All of us can get better. All of us can look at our personal life, that is the childhood experiences, parenting, and other things, which is the part of psychoanalysis. And all of us can become therapists. You don't have to be a doctor to be a therapist. So this was a very big breakthrough that moved the deviancy model to the normalcy model in a big way at the beginning of the last century. All of us know about psychoanalysis. We know about the wide range of conditions they took care of and how it dominates even today, the unconscious and the conscious and other things. But unfortunately, psychoanalysis had problems. It was too oriented towards a particular culture, Jewish culture to be specific, very expensive, very elaborate, and very long-standing. So it did not persist long. In 1950s, a couple of things happened which are very important for us to talk about cognitive behavior therapy. One was closure of the hospitals, what we call it as deinstitutionalization. This was largely because of human rights. More than that, the occurrence of the discovery of psychotropic substances, which moved people from hospitals as community to community as the hospital, which was a very important thing because suddenly mentally ill people had rights, and also their progress of illness was seen from more than the psychopathology. Let me just give you two examples to illustrate that. In the 70s, Dr. Leff discovered that among the people who are schizophrenics on medicines, some people relapse, some people don't relapse, and came up with the expressed emotion, saying that the family reaction, how the family criticizes or supports, makes a difference. Later on, another 30 years later, he discovered avatar therapy, how even the severe symptoms, 30, 40-year-old symptoms like hallucinations, can be controlled by the individual themselves, which when I did my psychiatry would have been blasphemy if someone talked about it. So we have come a long way from institutionalizing, deinstitutionalizing, and recognizing the power of the individuals to make a difference to their own mental health. That's where we come to the cognitive behavior therapy. Now, this is a really, really remarkable development by R.N.T. Beck. For example, when I did my psychiatry in 1972, the only thing we know about R.N.T. Beck was Beck depressive inventory to assess depression. You know, at that time, cognitive behavior therapy was not there. Even the Woolpace work of learning theories and behavior therapy was just beginning at that time. But what Dr. Beck did is remarkable. I want to pay my tribute to him. He just passed away about 4 years back in 2021 at the age of 100 years. What he did was, he said, I want to reconsider the whole of psychiatry as symptom-oriented to thinking-oriented. Just allow it to sink into your mind. The whole of psychiatry, from the bad, mad, sad, was all symptom-oriented. He said it is not the symptom which is important. It is the individual, the way he or she will think about it, react to it, which decides what will happen. Based on this, he built up a whole theory and threw away in the sense, put aside the unconscious mind, influencing thoughts and behavior, to saying that the way you perceive your thoughts, the way you perceive your emotions, the way you imagine the situation will decide the behavior that you do and the way you recover from the same thing. And to quote one or two things, and in point of fact, Dr. Martin Seligman says that Dr. Beck is the most important psychiatrist of the second half of the 20th century. That's real great appreciation for someone from positive psychology. Coming back to, in other words, Beck said, took something that most people think as the symptom and said it is actually the cause and we must address that rather than the symptom. What did he say further? We can work on challenging and changing the way we interpret thoughts. Doing that greatly reduces human suffering. Now, he didn't only say it, but he said this is practicable. It is not philosophy alone, it is practicable. And how do we do that? Dysfunctional thinking, which influences the client's mood and behavior, is the common factor. By learning to evaluate their thinking in a more realistic, adaptive way, they can experience a decrease in negative emotion and maladaptive behavior. Now, just see the real big shift that he made, that here is the person coming with a problem and saying that, look, you are not the problem. Your problem is not the problem. Your thinking is the problem. Then, of course, he went on to look at emotions, look at beliefs, imagery, and behavior. Now, in the therapy, another very important thing he did, he said the client is a collaborator in the therapy. Unlike in the Dorothea Linde Dix, he was thought to be violent, he should need to be controlled. In Freudian case, it was the therapist was sitting in the chair and the patient was on the bed, although he's surrendering to the therapist. Here, Beck said, you are the collaborator. The goal is growth, and much more than that, once you learn how to grow, you can generalize this for the rest of your life. Now, let's get to the nitty-gritty of the cognitive behavior therapy. What does the cognitive behavior therapist do? I will give you only the principle, not the examples of a practice. One is that to conceptualize the care in cognitive terms, not in symptom terms, not in behavior terms. Secondly, recognition of the thinking, emotions, and behavior, how they are connected to each other. You know, why are you feeling sad? Why are you feeling depressed? Why are you feeling angry? Because you are thinking that your situation is bad is the cause. Thirdly, bring about changes in the thinking, emotions, imagery, and then bring about changes in the behavior. Lastly, all of this would lead to new ways of looking at the situation, learning from one's own personal feelings, and developing a capacity to bring about changes. Usually, as all of us know, the sessions are usually 8 to 12 sessions, each session lasting about 45 to 60 minutes, with lots of homework for each person between sessions. You might say, how does this really work out in practice? As I said again, it is a collaborative in nature. There is a therapeutic elements between the doctor and the therapist and the client. There is education is the most important thing, and developing action plans appropriate to the person in his or her life situation is the core of it. all of this leading to a new person coming out of it, feeling more competent, more capable, and better control of his thinking, emotions, and imagery. Now, you would all be knowing that this was the core of the work that has been done. And Judith, who is his daughter, who runs the Beck Institute, is continuing the tradition, and it is widely there. And more than about 2,000 research publications have come from the time the first publication came in 1977. As it happens with our discipline, number of variants have come up. Some of them are, I'll read it out: rational, emotive, behavior therapy, problem-solving therapy, acceptance, commitment therapy, exposure therapy, cognitive processing therapy, mindfulness, cognitive behavior therapy. And one very important new development that has occurred, two developments. One is the internet-based, other one is what is called as culturally relevant cognitive behavior therapy. The first one to do this work was by Duke University, Koenig and others, who developed a RCBT, religious-based cognitive behavior therapy, for treatment of depression in chronic medical illnesses, using the principles of all the major religions as the resource to be able to base the interventions, thoughts and other things on the person, client's beliefs, practical situation and resources. And this has been done in a number of situations. One other person who has done a lot of work in this area is Farooq Naeem from Canada, who has worked with the Pakistan Islamic group and produced a lot of resources. So we have moved from a universal idea to a situation specific and resource specific to the particular situation. The other major development that is occurring in the last 10 years is the use of internet as the resource for this cognitive behavior therapy. Since the work is done by the client mainly more than the therapist, it looks very attractive to think of internet-based and all the other resource-based method. One of them, which was developed in Bangalore about 8 years back by Dr. Seema Mehrotra, is called PUSH-D. PUSH-D stands for Practice and Use Self-Help for Depression. This is a totally internet-based, self-generated program, and it has been tried it out and it has been found to be useful, except that the person has to be very sophisticated in his or her ability to use the thing in the internet. But interestingly, just about 2 years back, one of our students, Sindhuja Sudarshan, used this method in a hybrid model, in the sense that 4 to 5 sessions are face-to-face, another 4 to 5 sessions are using the internet model. And this has been found to be useful, and the doctorate has been done, and I've talked to her, and she says it's very acceptable to the people. One other variation that has occurred in Bangalore is, the number of research has been occurred, but time doesn't allow me to talk about all of them, was that to compare the acceptance commitment therapy and cognitive behavior therapy in depression by Saima Jamil. This also has been found to be very useful, acceptable, and practicable. So we have really a lot of things going for cognitive behavior therapy. Immediately you will say, Dr. Murthy, is it all honey and sweet? No, there are some issues that come up when you want to use it. First and foremost is that most of our clients in a developing country come expecting the therapist to do the work, not the person to be doing the work. That is the passive nature of the client is a barrier to start off. When you say that, look, we are going to work together, the person says, my God, I thought you were going to give me a medicine or you're going to solve the problem for me. The second one is there is a certain degree of educational background that is necessary for cognitive behavioral therapy, particularly the internet-based therapy, to be practicable. And we need, as I mentioned it, we need to tailor it to the local culture of the person rather than think of it as an international one. Even the term that we use it has to be different. Then we have to, from the beginning, teach the person, the client, that he or she is the active person And homework is an important part of it. And involving family members sometimes is useful. And the therapist has to know a lot more. For example, if I'm a Hindu, I need to know about Christianity, Islam, Jainism, Judaism. I can't just say that I will talk about my Hindu values to a Islamic patient or something like that. So we need to know the cultural resources and try to cleverly. I'll tell you an example of how this occurred. For example, I was dealing with a young, about 40-year-old lady who had severe grief because she had not been able to give her kidney to a brother who needed it, and he died. And she couldn't forgive that she has killed her brother. And everything I did didn't work till I told her the story of Buddha, where an elderly lady comes with her dead son, Kisa Gautami, and Buddha, instead of saying that I can't give life to him, he says, please go to the village, every house, and ask if there is no death and get mustard from them, then I will cure you. I'll get your son, bring him back to life. And she goes around and finds that every house has death, and she realizes cognitively that death is an inevitable part of it, and she becomes his disciple, and that's the story. So what I could not achieve with all my professional thing, I was able to do it with this simple story, because that story had a cultural meaning to the person, and it conveyed 10 times more than what I was communicating. I can tell you more stories of that type, but time are in the discussion. Now, so I would like to say that it is a fantastic development that has occurred. Not only it has empowered non-medical, I'm a medical person, so I can say it very easily, non-medical people to be therapists. Much more than that, soon we will reach a point where even ordinary individuals, without going to a client, will be able to help themselves to become better in terms of their mental health. Two other advantages are there. One is the reducing stigma. One of the biggest problems in mental health all over the world is stigma. I don't want to, I mean, you are seeing the story of Biden's possible mental illness in the original SIL book or other things. We are burdened with the idea of not wanting to seek help because it is associated with the stigma, negative things, while cognitive behavior therapy brings in a positive approach to the things. Similar to lifestyle, I'm going to come to that in a minute. The other one is very important to me. It talks about mental health, not mental illness. And it talks about population, not patients. These are big things in a world where mental health care is very, very limited all over the world. Now, I want to spend a few next 5 minutes on talking about lifestyle psychiatry. This is equally important. This is an emerging area for modern therapeutic one. The reason is that we have now recognized, particularly after the COVID-19, that all of us are vulnerable and all of us are capable of becoming strong mentally. This was reflected in the American Psychiatric Association last year. Dr. Vishwanathan, who was the president, chose this as the theme for the last 1 year, that is lifestyle, mental health, and for mental health and physical health, and lots of articles have come out. Essentially, what it means is that there are behaviors supporting mental health, and this can be used for prevention and treatment. What are these? Physical exercise, sleep, diet and nutrition, mindfulness-based interventions, social correction, social connectedness, spirituality. Each one of them has enormous evidence. Let me just read about the evidence for exercise. A few of the statements in the last few months. Lifestyle-based interventions are recommended as a functional component of mental health care. Exercise is effective for treating mild, moderate depression. Exercise remains underutilized. Exercise therapy is associated with reduced depression, anxiety in older adults with cancer, and so on and so on. And we can go on talking about it, any amount of it, in terms of the value of lifestyle psychiatry. So my own feeling is that we are going to, like cognitive behavior therapy came and empowered the person with the problems, saying that you are not the problem, your symptoms are not the problem, your thinking is the area where you can improve and become stronger. I want to close by saying that I have used this method in a self-care guide for caregivers of special children. What happened was, when we offered mental health care to them, they said, I'm not interested in it. I am interested in looking after my special child. We converted the self-care into saying that if you do this, you will live 10 years longer. All of this, the exercise, sleep, nutrition, meditation, all of these are, and what we did was, we converted them into pictures and made it very, very practical. And we have put it into practice, and it works, and people find it more acceptable than going to a psychiatrist, and they can handle it themselves. I come to the end of my presentation by saying that we have moved from bad, putting them in jail, to mad, putting them in asylums, to sad, taking them for therapy, to saying that mental health is relevant to each one of us. Each one of us is capable by our own resources to be mentally healthy, and if we become ill, to recover from it with our own efforts. I think this is a fantastic breakthrough in the thinking of the mental health area. I would end up this one saying that there will be more innovations in this area, and I congratulate I congratulate all of you for this special session, and I'm looking forward to listen to the Ayurveda as well as music therapy as tools or resources for mental health. Thank you very much.
Gratitude, Dr. Murthy, for giving us historical perspectives along with some interesting, intriguing anecdotes, narratives from the history, mythology, and from real life, of the journey of the discipline of psychiatry, and insightfully, brilliantly articulated presentation. Thank you so much for that, sir. And I also request you to please mention the name of the book that you have just showed us. Okay. And also let our viewers know where this book can be found. So
this can be, this book, I will put my email. If you send it to me, it is freely available, and I will send it by electronically, both in English and local language, Kannada, and this is available. And any other resources which I have referred to, I can provide that if people send me an email. Okay. I'll put it in the chat box.
Yes, please mention in the chat box.
I'll do that.
And I have a question for you, and that stems from my observation in the families of the friends and society at large. I have seen one of the biggest challenges that families often face when their loved ones go through this painful situation, and especially that is medication, because not every medicine can be given intravenously or in injectable form. So and majority of the time, that there is a challenge from patient's part, that families also give up, that patient doesn't want to take the medicine, what to do? So in your day-to-day practice, I'm sure you must have encountered endless cases of such challenge. How do you typically address it, and what would be your advice to the families who are going through this challenge?
I think it's a universal problem in terms of the person feeling that I am not ill, or I don't need medicines, or it produces side effects like sleepiness, putting on weight, slowness, and other things. The way I say it, luckily for us in India, this problem is much less than in the West, because the family is there. 99% of the people in India are staying with the family. What I find is that if the family can understand and make it a collaborative effort with the patient, rather than, for example, I tell them, saying that instead of saying that go for a walk, say, let's go for a walk. Let's go to the temple. Let's go to the mosque. Let's go to the church. Or let's go to the market together. Something similar to that, we'll have to develop it for the medicines. The other thing that is not happening adequately, Rajini, is that not many of us psychiatrists are treating the person as capable of understanding, and making the person a partner and see the medicine taking as beneficial. So the answer that I'm giving is, one is teach the family to make it into a part of the routine, taking the medicine also. Secondly, work with the person. Allow the person, like we do it in cognitive behavior therapy, allow not the symptom, but the thought. What will this medicine do? For example, I am a diabetic. I take medicines every day. I don't complain about it. Unfortunately, again, as I said, the stigma is what makes the person feel that, you are making me mad. You are calling me mad. What I do is that, look, you are not mad. This medicine is required. Similar to a person with diabetes or hypertension or asthma. And I get into that. And most important technique I use, Rajani, is to see the patient alone and have a dialogue with them. Otherwise, most of the time we do it with the family being there, then he cannot respect certain things we cannot do. The minute you allow the person saying that I recognize your personhood, I recognize your autonomy, I recognize your feelings, and set up that, rather than saying that I'll see you after 1 month or 2 months, come 1 week. Or now that we have phones, talk to me on the phone when you get upset. So you make it again, use the CBT techniques for that. But there are some people where it is a difficulty. I agree with you on that. Thank you very much.
Thank you so much for this precious advice, because I'm sure that there are many families who are facing this challenge would find this advice very beneficial. And we have another question for you in the comment box from Sebastian Nor. That is, does this mean that the underlying cause, which is not the root cause of the symptom, is what needs healing? And that this is healed by changing one's mindset, as you were discussing during your presentation about it's all in your mind. Yeah. So adopting a growth mindset instead of a set mindset, it's a rhetorical question, actually.
Yeah. No, I think there are, I forgot to mention one thing. There are certain conditions like personality disorders, person living in a very stressful, multi-stress situation, CBT will not help, because the thing is so overwhelming. Similarly, if the person is actively psychotic, at that point, it's not enough. But when the person recovers, it's helpful. But to a large extent, particularly if we start very early in the illness, it works very well. Only when it becomes chronic, what we used to call it as chronic, long-standing, then it becomes as. But in avatar therapy, again, they have shown that even the 30, 40-year-old auditory hallucination can be controlled if you have enough patience, enough work to do the person.
Thank you so much, sir. I'm sure this would be source of strength for many who are watching it and who would be watching the, this session is being recorded. So I'm sure this is going to be very beneficial conversations. And you have already given us assurance that you would be with us throughout the session.
I'm just going to put my putting my ears.
So thank you so much, because we are about to welcome our next speaker.